If any of you have problems accessing this presentation, please let me know and I'm happy to go through it with you. This presentation is about osteoarthritis. It will cover the pathology of OA, the risk factors for OA, the signs and symptoms that we see in patients, and how to manage osteoarthritis. Osteoarthritis is the most common cause of disability in adults, and it's one of the leading causes of loss of work productivity and sickness days, and one of the highest consequent medical expenses of all musculoskeletal conditions. Given the fact that osteoarthritis is the most common condition that you're probably likely to encounter as a student or as a physiotherapist, it's worth just talking about this concept very briefly, and it's called Occam's razor. Occam's razor says that the simplest explanation is usually the correct one, or the one that has the least factors to get to the decision. That doesn't mean that all of your patients will have osteoarthritis, but what Occam's razor says that if you have somebody who's older with all the symptoms of osteoarthritis and the presentation of osteoarthritis, that should be your starting point for a diagnosis. The danger here is that we pigeonhole patients into all having osteoarthritis, but I just think it was worth mentioning because physiotherapists love to make things complicated sometimes, and it's worth bearing in mind that common things happen commonly. So osteoarthritis is going to be a very common diagnosis for many of your clients. Osteoarthritis is a disease of articular hyaline cartilage. So it goes without saying that to understand osteoarthritis, we need to understand normal articular hyaline cartilage, which is a very well adapted and complex substance. This graphic here shows you the different layers of cartilage, starting with the bottom where it anchors to the subchondral bone and ending with the superficial layer at the top. Interwoven into this matrix is a very complex system of gag chains. You'll hear a lot about gag chains. Basically, a gag chain is a glycosaminoglycan, and in the next few slides, I'm going to talk about what they are and what they do. So let me introduce you to Gary the gag sponge. You can see that when I press Gary, he loses water, he forms, and then when I take the pressure off, he expands and sucks the water back up. That's what gag molecules do, especially when you rub them together. So that's why movement is very important for tissues in the body. When you cause movement in a matrix which contains gag molecules, they become electrostatically charged and they become even better at absorbing water. That's one of the reasons why you're slightly taller in the morning when you wake up, because the intervertebral discs have absorbed water and gradually that gets squeezed out throughout the day. As we get older, we tend to lose gag chains sometimes, and they tend to be not quite as good at grabbing hold of water. And that's one of the key changes in osteoarthritis. Gag molecules are also extremely slippery. So just as a couple of examples to try and help you imagine what they are, the drug heparin, which is used as an anticoagulant to make clots more slippery and dissolve, that's a gag molecule. And also the slime that snails and slugs produce is also a gag molecule. In this graphic, we can see a cross-section of normal articular cartilage and then articular cartilage which is beginning to develop osteoarthritis. Normal articular cartilage is very slippery and has the consistency of a wet ping pong ball. So if you get to go and watch theatre surgery, so an arthroscopy, for example, you'll get to see this. It's extremely slippery. And the normal coefficient of friction between two articulating surfaces is much less than one ice cube against another. So that shows you how slippery it should be. One of the first things that starts to happen is that the articular cartilage starts to dry out. Tiny cracks start to appear. This is all still asymptomatic. It doesn't have any symptoms at this point because the cartilage itself doesn't have a nerve supply. The reason that the cartilage doesn't have a nerve supply is that because it's very soft and spongy. So every time you stand up, or put weight through your joints, you're deforming the cartilage. If you had a blood vessel or a nerve running through that, it will be destroyed immediately. You have to feed the cartilage from the outside, which again is why movement is so important in terms of synovial sweep in our joints, which you'll talk about quite a lot. So this is the first stage of osteoarthritis, and this is called fibrillation, where we get these tiny cracks. You'll also come across the term fibrillation in the heart, where you get an uncoordinated beat of different muscles at the same time. But in rheumatology, fibrillation refers to the small cracks that appear in the cartilage. These cracks start to get deeper and deeper and may even go into the subchondral bone. At this point, they start to become painful because the bone does have nerve endings. We may also find that synovial fluid gets punched through these cracks into the bone and causes little cysts, which are very painful. This picture here shows two femoral heads. The one on the left is relatively normal, almost slightly osteoarthritic, and the one on the right shows advanced osteoarthritis. So you can see how the one on the right has lost its glossiness, it's started to lose its shape, and it's no longer going to fit properly in the acetabulum. When you're on clinical placement, you'll have chance to go to watch surgery and you'll hopefully see arthroscopically what articular cartilage looks like. This is a normal knee joint. What you can see here is the femur, the tibia, and one of the menisci, and the appearance here is normal. If we now look at the findings in an osteoarthritic knee, we can see the differences immediately. So that smooth appearance of the cartilage is now gone and it's been replaced with a rough and furry appearance. That's OA. But again, you can see the femoral condyles, part of the meniscus, and now you can actually see that the cartilage on the tibial plateau has worn away so much that we're now exposing the subchondral bone, which is slightly pink in colour. Just for interest, this is somebody about to undergo a knee replacement, and what you can see here is the base of the femoral condyles. You can also see the cruciate ligaments as well lower down, and you can see the metal retractors just to expose the area. What you can see here is that one of the femoral condyles is relatively unaffected. It's quite nice and shiny and smooth. But you can see that here on the lateral femoral condyle, the articular cartilage is worn away completely and we're now down to the subchondral bone. So this will be a source of quite severe or chronic dull aching pain in this person's knee. Here are two x-rays of knee joints. The one on the left is normal and the one on the right's got severe osteoarthritis. So you can see the femur, the tibia and the patella. And you can see what we call a joint space. It's not actually a space, but because the articular cartilage doesn't really show up on an x-ray, it looks like a black space, which is normal on the medial and lateral compartments of the knee here. If we look at the right-hand side photograph, we can see that that space is much less, especially on the lateral side. You can tell it's the lateral side because you can just see the head of the fibula poking out. Also, I want you to note how you can see there's a white line on the upper surface of the tibia. That's called sclerosis or eburnation, and that's a response of the underlying bone to the stresses and strains to put down more calcium to try and ease the pain and suffering. There are two types of osteoarthritis, primary and secondary. Primary is mainly a genetic component and it tends to be found in postmenopausal females, not only, but tends to be. Whereas secondary osteoarthritis has had a predisposing cause, something like a ligament injury or a fracture or an infection. So if you have a look at the content of this slide, it's interesting to note that even though osteoarthritis is extremely common, we don't really yet understand what gives it some people and other people are spared from it. It's certainly got a genetic component, especially with primary osteoarthritis. And there's also a link to previous trauma with secondary osteoarthritis. And there is a link to being overweight. But even that's not quite as clear as we thought. It's not purely the weight going through the joints. It seems to be that being overweight causes our adipose tissue to produce these cytokines, which are inflammatory cells, which cause inflammation. So it's not the actual physical pressure of the joints, although that is a role. It's also what it does metabolically to have increased adipose activity. For a lot of the diseases that you'll study, you'll start to find a pattern that there are kind of three components at play: genetics, environment, and activity. And I think with primary osteoarthritis, that's certainly true. So a good way to think of it is that genetics loads the gun and environment pulls the trigger. This is something that you'll find very commonly, this interplay between genetics, environment, and occupation, all going towards producing a disease or a pathology. You will, during the course of your clinical practice, encounter people with hands that look very much like this, almost always postmenopausal women. This is primary osteoarthritis, and these swellings are called Hebriden's and Bouchard's nodes. And primary osteoarthritis has a very typical pattern of affecting joints, to which tends to affect the fingers, the distal joints in the fingers, whereas rheumatoid is slightly different. The base of the thumb, the first metacarpal joint of the thumb, the cervical spine, the lumbar spine, the hips and the knees as well. And here is a close-up of somebody's hand. This person has primary osteoarthritis. And you can see here, I've tried to illustrate the joint pattern of primary osteoarthritis. So if you see a patient with hands that have got these bony swellings, it's a very good bet that they've got primary osteoarthritis, and they will probably have pain in these joints as well. And again, just a reminder, it's not purely obesity that leads to osteoarthritis, although that is a factor. If you are overweight, studies have shown that it puts multiple times of your body weight through the lower limb weight bearing joints. So losing weight is certainly a good idea if you are overweight as a patient with osteoarthritis, but it's not that simple. It seems to be thought that now, if you have increased adipose cell activity, that actually starts to act as a gland and produce these hormones which are inflammatory in nature, and that seems to accelerate osteoarthritis as well. The evidence about activity is different really. It's controversial. Joints don't mind being used normally, but they don't like being used abnormally. And there is evidence through history that people who've done heavy manual labor do suffer from more joint destruction. So, for example, the people who built the pyramids, if they were carrying heavy weights, they had an increased risk of osteoarthritis in the lumbar spine. But it seems that generally normal activity is good for our joints, which you will learn about in terms of synovial sweep. So the evidence is still a little bit sketchy. Quite often diseases are divided into primary and secondary. So, for example, frozen shoulder, a primary frozen shoulder comes for no apparent reason. A secondary frozen shoulder comes after you've had your arm immobilized in a sling for 6 weeks. Same kind of thing with osteoarthritis. Secondary osteoarthritis has some other predisposing factor, and there are lots of them. So that can mean congenital birth defects. There's a condition called CDH, called congenital dysplasia of the hip. That means that the acetabulum doesn't sit properly with the femoral head, and that can cause abnormal movements. Diabetes seems to increase the risk as well. Ehlers-Danlos syndrome is a condition where joints are tending to be hypermobile. Marfan syndrome is a genetic condition which also predisposes one to osteoarthritis. And then things like rheumatoid arthritis, any disease of the joint, can also exacerbate the degeneration of the joints as well. True story. When I recently graduated, I was working in a rheumatology orthopedic unit, and I ended up treating a player who was a very high level rugby player. And he'd come in for a relatively routine arthroscopy of the knee. And what had happened was that the nurse had given the surgeon formalin rather than saline to irrigate the knee at the end of the operation. And the surgeon had injected this formalin into the synovial cavity, which is very corrosive. And I treated this patient afterwards, and basically he had an X-ray every 4 or 5 months after this, and you could watch the changes in his knee as it aged rapidly from the joint destruction and the damage. So that was an example of secondary osteoarthritis. You might also expect somebody after a ACL injury or severe ligamentous instability to have an increased risk of osteoarthritis in their later years because of the abnormal movement that results from lack of stability of the knee. You'd also find the same thing following intra-articular fractures, in other words, a break into the bone joint itself. Osteoarthritis is also particularly common in the lumbar spine and the cervical spine, and in the same way that you get these osteophytes, these spurs of bone which form little lips around the margin of a joint to try and stop it from moving, you get the same thing in the lumbar and cervical spine. So on this X-ray, you can see these little projections of bone spreading out sideways, and you can also see on the bottom joint, the joint space is severely diminished between L4 and L5 vertebra. It is important to note, though, that there isn't always a correlation between what the X-ray looks like and what the patient presents with. So it's possible for the X-rays to be normal, but the patient have a lot of pain, or it's possible for this patient here to have a very obvious pathology in the lumbar spine, but not have any symptoms from it. This is the X-ray of somebody about to undergo a total hip replacement on the right side. This is a female patient. You can tell by the angle of the pubic bones meeting in the middle. But if you look at the right hip, you can see how the cartilage is worn away completely. We've also got some cysts in the acetabular area. Compare that to the left hip, where the joint space is relatively well preserved, and it kind of still looks like an egg in an egg cup. Again here, severe osteoarthritis affecting the hip joint. I've included this just to show you how this person's going to really have very limited movements in the hip because the biomechanics are just not possible. It's not possible for this person to move the hip much anymore. And look how close the greater trochanter is to the bone now. So there's going to be a lot of impingement there. Compare that to the lower photograph, which is a normal hip joint. This X-ray shows you two things. It shows you, first of all, this subchondral sclerosis or hardening of the bone. It's also called ebonation because the bone becomes like ivory, very tough, very dense. And that's the body's response to the loss of articular cartilage. You see this white line, which is an indicator of OA. You can also see a cyst, which I'm going to show you in the next photograph. And here he is. So you can see this cyst in the pelvis here. This is going to be a cause of pain probably because the blood pressure in here is quite high and bone has a very good nerve supply. So this is going to cause a deep aching sensation. And this has probably been caused by cracks in the articular cartilage, which have allowed synovial fluid to be punched through into the bone cavity itself. We tend to have a 1 to 4 grading system for osteoarthritis, which I think it's worth having a look at when you get the opportunity. Here's a slide of what's going on. On this slide, I've tried to separate what happens to the cartilage and what happens to the bone in osteoarthritis, since they're both closely related. So at the molecular level, the proteolytic matrix becomes degraded and these gag chains are affected, and we get fibrillation in the cartilage, this roughening, and that can cause a loss of volume in the cartilage. We don't quite yet understand what happens in the bone, but certainly one of the responses of the body is to put down extra lips of bone, a bit like petals on a flower, to try and spread out the load and stop the joint from moving. They're called osteophytes. The cartilage around the joint can start to ossify in response to the increased stresses and strains, because the bone just isn't as good at absorbing stresses and strains as the older cartilage was. There are changes in the vascularity and the blood pressure in the subchondral bone that probably causes quite a lot of pain. And then we get this cytokine storm. So cytokines are inflammatory chemicals that tend to go out and cause us pain and inflammation. Signs and symptoms of osteoarthritis are fairly straightforward and predictable, really. Don't forget that a symptom is something that a patient complains of, and a sign is something that can be tested for or measured objectively. So these are basically the signs of inflammation. So you've got pain, stiffness, loss of movement, swelling, crepitus. Crepitus is a sustained creaking of a joint. It's not the same as cracking your knuckles. Crepitus is a sustained cracking or creaking, which can be severe. What I want you to look at here is this knee joint. So I want you to look at two things here. First of all, there is relatively good joint space on the lateral side where the head of the fibula is, but the medial joint space is starting to wear away, labeled number one. And also the arrows pointing to number two are the beginnings of these osteophytes, these extra pieces of bone laid down to stop excess movement. And they themselves can become a source of pain and irritation if they get trapped or squeezed or nipped. This list is what we think of currently as the major predisposing factors for osteoarthritis, so have a read through this in your own time. Some of these are modifiable and some of them are not. There are criteria for the established recognition of osteoarthritis. Basically, it will be diagnosed by clinical signs and symptoms, really, in conjunction with X-ray findings as well. So typically more than 50 years old, some morning stiffness, not necessarily a lot in comparison to something like rheumatoid, which is off the scale morning stiffness, crepitus, bony tenderness. You might actually see or feel bony enlargements, and you might occasionally feel some warmth in the joint, depending on whether it's flared up or not. On X-ray, we will see the typical osteophytes, the loss of a joint space, subchondral sclerosis, or this whitening of the bone, and possibly subchondral cysts as well. In terms of management, it's obviously a very common condition and a very variable condition. Some people don't need to have any interventions, and some people need to have total joint replacements and everything in between. So these are just a general list of suggestions. Don't forget the multidisciplinary team. Don't work alone. Think about other people that can help you in helping your patients. That's going to give the patients the best outcome. But things like advice about weight loss, healthy nutrition, obviously, an exercise program, all the evidence suggests that if you keep going and keep your muscles strong and keep your joints moving, these are the people that tend to do better. Um, Low impact activities, things that don't make it worse, no problem with that. It may be that the patient needs a stick or a walking aid or a crutch or some orthotic to correct a deformity or even knee braces as well. I think the important thing to recognize for you guys as newly qualifying physiotherapists is the role of the internet. So there's a lot of stuff out there about I can cure arthritis. Be very careful with that. That's one of the reasons why we stress to you that you need to look at the quality of the evidence that is out there. And there are a lot of people out there making a lot of money from unsubstantiated claims about what they can do for osteoarthritis. So just be aware of that. And if you are a patient with a condition, the first thing you're going to do nowadays, 50 years ago, you would have gone to the GP and listened to what they said. Now you're going to go on Google and listen to what Google says. So just be aware of that. So one of your roles is to give the best evidence-based advice that you can. In terms of medical management, obviously pain relief might be important. There's no reason why patients shouldn't take painkillers if they need them. There are some patients out there that have a real problem taking painkillers and some people that take too many. Simple analgesics are probably going to be as effective as anything else, but it is important that you keep an eye on the current NICE guidelines. Non-steroidal anti-inflammatories may have a role, and steroid injections may help, although the inflammation in comparison to rheumatoid in osteo is less. There are also now synthetic synovial fluid replacements as well, which the evidence is starting to become a little bit clearer, but we're not quite there yet. It may be that surgery is indicated, and this is a decision for the surgeon and the patient to make with other members of the team as well. But the results of joint replacement surgery now are extremely successful. We always should keep an eye out for new developments. One of the relatively new developments is PRP injections, platelet-rich plasma, which involves taking the patient's own blood out, centrifuging it, separating out the platelets and re-injecting them back, presumably as an anti-inflammatory type measure. Have a look at what the evidence says about this. When I last checked, the evidence was not completely convincing, but there is some research being done on that at the moment. One of the treatments that you might come across now is microfracturing, which is kind of an odd thing, really. These two photographs show you a femur which has lost the articular cartilage. The big metal thing is the probe there. And you can see how the articular cartilage has worn away from the center here, and you can see the pink underlying bone. One of the things that seems to help is to put tiny drill holes in the bone, and that kind of considers to remold the bone and remodel the bone, and that seems to help in pain, and that's called microfracturing. And then finally, it's your responsibility to keep up to date with what the latest thought of treatment options are, and the best way to do this is to keep an eye on the NICE guidelines.